Exceptional. Okay, so, and also just a reminder, if you could please use the chat, because we are running into some difficulties of hearing you, unfortunately, while we have the microphone on here. Okay, so we're going to let Jamie take it away.
All right. Perfect. So I'm Jamie Gallup. I'm with the Community Hospice. Community Hospice covers up in this area, Washington County, and then down into Saratoga and Schenectady, and even further below, we cover 8 counties. And today what we're going to do is just talk a little bit about the difference between palliative and hospice care. So this thing does work, which is amazing. Yay. My fingers don't work, but that works. So really today, quickly through this presentation.
Are we good? No. It's only staying on the first page? Yes.
Oops.
Do I have to go?
I think she might be sharing the wrong one.
What?
I think you might be sharing the other PowerPoint that you have up, maybe.
Which one is on? What you got? Your thing. Understanding. So the first, I think each time it changes, you have to share the new screen. Does that make sense? Are you serious?
I don't know. We'll pause.
If you hit the escape button, perhaps. No.
There. Oh, no. Yeah.
Is it good?
It is, but it's showing your notes. Is that okay?
Oh.
No.
I mean, if people want to read my notes, there's nothing bad in there.
Breathe. Okay, pause.
Yeah, right?
Again,
Pause
I
for
am so
applause.
thankful for this group because everybody is super supportive. You're not going to find anybody, even the people, anybody would be critical in any way, so don't worry. How does it look now? Perfect.
Beautiful.
Exceptional.
Yes, we need to technical. All right, so we'll go through what is hospice and what is palliative care, explaining when to consider and connect with palliative care, the criteria and expectations for hospice care, and then really the big goal is to define the similarities and differences between palliative and hospice care. So yeah, we'll get.
I was going to do that.
All right, next slide. Oh my goodness.
It's fine.
All right, while she's getting the next slide, I'll just talk about the next slide. How's that sound?
That sounds fabulous.
Okay.
I love that for us.
So really our goal is to plan. All right. Planning when the skies are blue and not when the skies are gray. So really navigating these conversations and normalizing the terms hospice and palliative care. It's never too early to know your options, and really the worst time to plan for something is when the crisis hits, right? We want to have a plan in place and know what to do. It's important that people are aware of the care and services that are available should they need them. We want to really normalize, again, those terms, hospice, palliative care, and empower people to make informed decisions about their care, and that comes with a realistic view and at the diagnosis and the options around them. So we want to set goals around care and help get caregivers on the same page. So really, let's be proactive. Let's get these services in place to help manage diseases and any situation that may arise with it. So if we look at the old versus new approach to care, the old model is we would, have a doctor diagnose someone with a serious illness, and they are going to provide this life-prolonging care, as long as they can, life-prolonging, and refer to hospice at the very end of someone's life, and then really provide that bereavement afterwards. However, the new model, we're allowing that life-prolonging care with that serious illness, and then adding in palliative care with it to help manage the symptoms of the disease, and then we can bring in hospice care when the person has a prognosis of 6 months or less. So the new model of care is allowing that life-prolonging care with palliative care to provide symptom management and really help And we'll talk more about palliative care in just a second, and then bring in the hospice care when needed. And as you can see, palliative care goes into hospice care. Okay. So I'm going to go. There we go. You just got to click it a couple times. So what is palliative care? So palliative care is specialized medical care for people living with a serious illness that's chronic and progressive. So patients receiving palliative care may receive medical care for their symptoms or that palliative care, along with treatment intended to cure. So palliative care, that's compassionate care, really meant to enhance a person's current care and focus on their quality of life for them and their family. So palliative care addresses those symptoms to improve how a person feels. It's really this comprehensive, holistic approach to improving quality of life for an individual who lives with a serious and potentially life-limiting illness. And that goal is to relieve the suffering of the symptoms. So when someone has a serious illness, you know, there's sometimes a lot of pain or emotional stress, depression, anxiety, fatigue, nausea, difficulty sleeping, shortness of breath, all of these things that the palliative care team can help address those symptoms. So the team's made up of doctors, nurses, social workers, nutritionalists, chaplains, and many, many more. So that can be, palliative care can be provided in hospitals, nursing homes, and even there's home care palliative care options. And with palliative care, co-pays may occur. It's really based on insurance. And then really, palliative care is not this hands-on care. It's more of that holistic approach to manage symptoms, to manage pain, to really help with emotional aspects of what is going on with that serious illness. Palliative care team can also help somebody really understand their illness. So it's available at any stage in that illness or disease when there's still hope for a cure. So the team can help alleviate those side effects that come with the curative treatments. As we know, those can be really, you know, not great. So the palliative care team can come in and help with those symptoms. And when it's time, the palliative care team can affirm the end of life and dying as a normal process. So really, the palliative care team can help define and align goals of care through ongoing discussions of diagnosis, treatment plans, patient goals, and advanced directives, which we know are very important to have in place. They're attentive to the patient and the family in resolving conflicts, because this is a very tricky time. We know that families can have different ideas of care, and the palliative care team, especially the social workers, can come in and help resolve any conflicts and really help manage those conversations. We know that advanced care planning can also improve the mental health outcomes of family and caregivers. Once that plan is in place, it can really help ease that stress, ease that anxiety that might come with a serious illness.
That was weird.
You know, we just have all the technology talking at us right now. So you might be asking when to consider palliative care. So a person can join palliative care at any point, really, in their serious illness. So a person who's declining in function, you know, it's harder for them to complete tasks or activities of daily living. They may have more frequent trips to the ER because of their illness and want to have this palliative care that can help manage those symptoms. They might have a limited support system at home, making it really hard for them to manage their disease or illness, or they might not understand what is going on. What is, you know, a typical progression of their disease, and palliative care can come in to help and give more information regarding their disease. They may have trouble taking medications appropriately or showing up to outpatient appointments and need support managing that. And they may have been referred to hospice but don't meet that criteria yet. So they've declined a hospice referral and palliative care because there's still maybe not a 6 months or less prognosis, so palliative care is more appropriate at this time. So the most important thing I think really about this palliative care is to define those patient goals. So it might seem too early, you know, in someone's disease or in their illness to discuss a patient or loved one's goals or end-of-life wishes. But if we really don't start that conversation now, it might become too late. and the family's left wondering what their loved one would have wanted. So palliative care can really help not only managing the symptoms, managing the treatment, managing the disease and the prognosis, but also with these advanced care planning, which are so important to have in place. Any questions regarding palliative care? I'm going to kind of do these in two segments, so palliative care, hospice, and then...
There's a question in the chat.
Yes.
If they'll be able to obtain the slides.
Yes.
I have a question about,
Mhm.
how does one get into it?
How does one...
How does the whole process get started to get somebody into it? Is it doctor referral?
Yes, usually doctor referral, but then patients can always advocate for it too, or family members. So if you're in the hospital, say, and you're being discharged, you can ask for the palliative care to get that referral. I know where we are with St. Peter's Health Partners, we have a palliative care in the hospital, but we also have outpatient. I believe Albany Med does too. I'm not entirely familiar with the Adirondacks region, but I think you have
We have
palliative care as well. So, Glens Falls, okay.
High Peaks Hospice
Hudson
directly.
Headwaters.
Can a family call High Peaks Hospice
Yes,
or
for
hospice
hospice
directly?
services, yes. We don't do palliative
Right.
care
Okay.
services at hospice.
Okay.
Mhm.
Hudson Headwaters is starting a program through them,
Okay.
but to get a referral for hospice, you can
For,
contact them.
okay, how about for palliative care? Can the family call directly?
Mm-hmm. Yes, but they would then, so the family, well, the community hospice, we don't have palliative care either.
Okay.
It's through St. Peter's Health Partners,
Okay.
so the family could request it, and then, but they would need the doctor's referral.
Okay.
I'm just gonna, I would assume that if someone wasn't sure, and they were to call one of your
Mhm.
hospices and say,
We
we want palliative care,
Mhm.
they would say, oh gosh, we don't do that, what area are you in, here is the area, here is who
Absolutely.
would be providing that palliative care service.
Okay.
Absolutely.
So Hudson Headwaters,
Hudson Headwaters.
starting it or doing it?
They have a Homeward Bound program, which has a lot,
Which is
palliative
yeah.
care services.
Okay.
Yep.
They're starting a new PACE program.
Yes, yes,
Mhm.
yes, yes.
And, so there's definitely some options in the Adirondack area.
Absolutely.
Thank you.
Great. Okay. So we will go through hospice. So, as I turn all my pages. So hospice focuses on care, comfort, and quality of life for a person with a terminal illness approaching the end of life with 6 months or less. It's comfort rather than curative. So if we think versus palliative, where we could still have that curative treatment, hospice, somebody is choosing comfort rather than curative treatment for that specific illness they came on for. We have a large team that joins when somebody joins hospice care. It's a team made up of doctors, nurses, LPNs. We have social workers, chaplains, trained volunteers, bereavement teams, and complementary therapies like Reiki, massage, healing touch, and music. We once had a therapy pig.
I think
Yes.
that's very important.
Very important to have that therapy pig. But hospice care, it's available in the home, nursing home, hospital, or separate hospice centers. We know a lot of people, their choice is to come home. They want to be surrounded by their loved ones. And with hospice, we can help them get home and have that be where they choose to pass. So with hospice, when to consider hospice, I guess, is if you are if we're thinking about a loved one, or we're thinking about maybe a patient we work with, these are some signs or symptoms of when to consider hospice care. So somebody who has a terminal diagnosis, somebody who has 6 months or less, and they're having trouble swallowing or choking, or they're having trouble eating, maybe a person with dementia who's having worsening symptoms like inability to communicate and walk, progressive weight loss, even if they're eating because something internally is going on. These persistent symptoms, such as pain, nausea, shortness of breath, that are caused by that terminal illness that they have. Desire of the patient or the family to stop uncomfortable or ineffective treatments. They've tried curative treatments, it's ineffective at this point, and their desire is to go on to the comfort care. So they do not want to, avoid those rehospitalizations, emergency visits that are related to the terminal illness. Those are very, very, thinking of the word, like, disruptive. That's the right word. I was thinking destructive, but disruptive. So having those rehospitalizations, the emergency visits. It's disruptive to the family. It's disruptive to the person. It is very, very tricky to, when we get people in the ER, they're there for a very long time. And it's very disruptive. It's harder on older adults. It's harder on family members. So the desire to avoid that. So just disease-specific criteria. I'm not going to go fully through this just based on time, but if you can read through these are, when treatment's been exhausted, there's no other really interventions to go through. Somebody's having that severe dysfunction, major organ failure, systemic failure, end-stage disease, those sorts of things. The disease has progressed despite treatment, and a person's severely limited by their disease and symptoms that come along with it. So the admission to hospice. So we talked a little bit about some of the criteria, but there's 4 criteria really for somebody to be admitted into hospice. So we have 2 physicians must agree that there's a terminal diagnosis. So if the disease were to run its natural course, the person would pass. A life expectancy of 6 months or less if the disease were to run its natural course. And then the person must forego any curative treatments for that specific disease they came on for. So if they came on for cancer, they're foregoing chemotherapy, radiation. If they came on for other things, it's case by case. Every person is evaluated by the doctors on an individual basis. So there's no, if somebody has this is exactly what hospice will look like for them, because everyone is different. Everyone's going to be having a different plan of care. We really, I think at hospice, the most important thing is that we respect everyone's choices, their rights, their desires. So if somebody is admitted into hospice and they choose that this is not for them, it is absolutely their right to discharge themselves. I think once people come onto hospice care and their families get all of that extra care and support, a lot of people are like, this is what we need for our family. This is what my loved one needs. So they choose not to discharge themselves, but however, that is their right. That is their choice. We absolutely respect that. So really our goals we talked a little bit about, but to manage discomfort, to minimize symptoms, maximize quality of life. I think at hospice, our people are those end-of-life and end-of-life care specialists. So they want to provide a good death for the person and their families. We focus on celebrating life. So at hospice, we say that we make the days count rather than counting the days. Because people have things that they want, they wish to do, and with hospice, we can help them, cross off things off their bucket list. Just because a person comes onto hospice care does not mean that they're going to pass in a day or 2. Okay. So quickly, I'll just go over how it's paid for. Hospice is a right of benefit, meaning that it's written into all insurance plans. There's never, ever a cost associated with hospice. So if somebody's be discharged in their home, their hospital bed is completely covered. They need a commode covered, incontinence products, which are ridiculously expensive, all covered. So at hospice, we cover people who are uninsured. We cover people who are without a home. We will find them a home because we believe really that people deserve a dignified end of life. And we'll never, ever ask about documentation status. So really the goal is to provide that dignified end of life. And questions on hospice? Okay. So now, kind of where we were going with this whole presentation is talking about the similarities and differences between the two. So now that you have the idea of what each one is, how are they similar, how are they different? So all of hospice is palliative care, but not all of palliative care is hospice care. So these are kind of some of the similarities. You can read through them. I'll go through some of them very quickly, but both offer that symptom and pain management. Both provide an interdisciplinary team. Both goals are really to support that patient and family and their caregivers, improving the comfort and well-being, providing support and expertise, and really managing anxiety or maybe that stress that comes along with a person who joins either palliative or hospice care, and to make that caregivers have the most of their time with their loved one. So the difference is palliative care is appropriate at any time in a serious illness, whereas hospice care is provided for those in the last, 6 months or so of their life. Palliative care is provided at the same time as that life-prolonging treatment, whereas hospice care is provided, that's that comfort care rather than curative. There's no prognosis requirement for palliative care, so a doctor doesn't have to say, there's 6 months or less, whereas with hospice care, two doctors must certify that. There's no need to choose between treatment approaches with palliative care, whereas with hospice care, the person is foregoing any curative or life-prolonging care. Palliative care does not provide that hands-on care. It's more of disease and treatment management, whereas hospice provides hands-on care. Nursing goes in either wherever that person chooses to live. I'll just let you look through this slide again. But studies have really shown that people who have hospice and palliative care can actually live longer because they're receiving that extra care, extra eyes, extra support, extra hands. So they have more quality time to stay and live with their family. So their caregivers have less stress, there's less reliance on the caregivers, whereas without palliative or hospice care, there's a lot more stress on the family and caregivers. So really that importance, like I just said, the studies have shown that people can actually live longer. 95% of hospice patients and families wish that they had joined hospice sooner. So I think a lot of times when we hear that word hospice, we think last couple of days, last couple of minutes almost with a loved one, but that is not the goal of hospice. The goal of hospice is to connect people with those care, support, and services sooner rather than later so that they can have all this extra care support and their families have less stress. So navigating these conversations, these are tricky, right? It's not easy to talk with a loved one about palliative or especially hospice care. So some tips are to use articles, TV shows, movies, or current events. President Carter has been on hospice care for over a year, so even talking with a loved one, bringing that up is a good way. It doesn't have to be like, Mom, what are your thoughts on hospice? It can be very natural, very organic that way. Share your own feelings about the death of someone that you know. Talk about the values and ask them the same questions. So what makes your life worth living? What matters most to you? These are not going to be a one conversation. It's not going to be, okay, let's write down, it's going to be more than one conversation. Hospice is always welcome to be a part of that conversation, the palliative care team as well. So if this is something that you or a loved one really needs help with, absolutely contact hospice. We can help with those conversations. We can help be a person in the room to have that conversation with. So family members are never, ever alone in this.
You have a question in the chat?
Yes.
What are the costs?
With hospice?
Yeah.
So there's never a cost with hospice. Hospice, everything that is associated with that hospice care and hospice diagnosis, it's completely free. So medications, nursing, complementary therapies, it is absolutely free. No one would ever have to pay.
Where do you get your funding?
Through Medicare, Medicaid. It's written into insurances. It's a right of benefit. It's written into my own. I had to dig deep into it, but
they're required to.
It's required.
Cover that.
Mm-hmm.
Yep.
And then if anyone is uninsured, we still cover them. We have something called the WISH fund.
Okay.
So, but we never want to turn someone away from hospice because they can't afford it, or they don't have insurance, or they're undocumented, or our social workers work really hard. Even if somebody's on home, they have places that they can get them to.
And then there's another question. What does it look like if someone lives?
So the question is, what does it look like if someone lives?
So they're discharged from hospice or graduate. There we go. So someone can be discharged or graduate from hospice care if their prognosis or terminal illness, or their prognosis doesn't look like 6 months or less. So the doctors recertify them every 90 days, and then after every 60 days, so every 90 days for the first 3 months, and then every 60 days. So the doctors go and they say, is this prognosis 6 months or less? If not, they are graduating from hospice care, but if they decline, they can join hospice again. We've had people graduate and go on to live for 3 years. We've had people graduate and come back onto hospice care. I talked with someone who was working with a resident who graduated 8 times. It's just that extra care and support, people can rally sometimes, and they can go on and live and not join hospice again for a couple years, or they can join when their prognosis looks like that 6 months or less, and they have that terminal illness.
What does it look like if someone lives alone and does not have support?
Oh, great question. So if someone lives alone and doesn't have that family support, so with the community hospice, we are not 24/7 care. We can't provide that, unfortunately, but people do have access to us 24/7, so we would have social workers go in if needed. Social workers could connect with people in the community, whether that be aid services, whether that be if they needed to go into a nursing home or something like that, they could help with that transition. But a person would have access to hospice 24/7, so if something happened in the middle of the night, a triage nurse would talk them through whether they need to send out a nurse or whether it's something that in the morning a nurse could come out to. So unfortunately, we don't provide that 24/7 care.
How does it work with specialized houses, like for instance, James House of Hope?
It's over near Granville.
So
Is that a part?
that's part of
Okay,
our-
I was like, I don't know that one.
So
That's part of High
we
Peak.
work right with them at
Yep.
High Peak, so we'll go, our nurses go right in, our social workers, our chaplains, we work very closely with Haynes House, and we would all still go in there. Usually, so for Haynes House, all the time, I would say, they're on hospice, and then they go into Haynes House, so it's kind of, we facilitate for them to go there.
And can you explain for anyone that might not know what Haynes House of Hope is? It's a hospice house, so it's a volunteer-led house
Okay.
for people that might not have their own residence, or they live alone in their own residence, and they want to go into somewhere that's just more suitable for hospice to come in. It's a 2-bed facility, so 2 patients at a time. If you're certified eligible for hospice, and there happens to be an opening, you go in there, live in it like your home. Your family will visit you there. There's extra rooms for them to stay. It looks like a residential house. It's all volunteer-led. Well, it was all volunteer-led. Now they do have some paid staff who come in and do the cooking, the cleaning, something like LPN nurses there. They can administer medications, just all the things that your family would do if you lived with your family. The volunteers and the staff at the home do.
What stage could somebody go into?
Typically, the prognosis is 3 months or less. Typically, for Haynes House is what they try to aim for. But it's not something that if our patients live longer than 3 months, they don't kick them out or anything like that. It's just like with hospice. If you live longer than 6 months, you stay on, as long as you're still showing decline.
Thank you.
Any other questions, or are we, nothing there, Steph? Nope.
All right, so
Okey-dokey.
we'll send out, this is me, if you have questions. Again, community hospice covers 8 counties. The one up north is really Washington, but if you have people in other counties that you work with, just reach out.
Great. Very good. Thank you.
Thank you. Thank you so much.
Thank you.
And now,
Still in the middle of this camera. Do you want to?
okay.
I don't
and-
think they can see us. I think they only see
Maybe
the
a little.
patient.
Oh.
I can see it.
Oh,
If
you-
I open up my thing, I can.
Oh, you can?
Then you
Okay.
can.
Fine.
Yeah, depending on what you, yeah. So, we will move on to, High Peaks Hospice. We really appreciate both, all of you being here today. And the next part of the presentation is gonna be about, the 5 wishes, for anybody who is familiar with that, and hopefully there will be people who are not, so that they know, it is an option, which is a way to kind of formalize and really kind of have an outline of some of those critical conversations that, we hope that all families will have, and how to start them so that you can support your loved ones through their decisions. and then how hospice can help fulfill those wishes when they have been verbalized. So if you give us a second, we're switching to our new.
You gotta bring the TV so this, in the chat, you gotta, thank you.
Oh, wonderful.
Okay. We thank everybody for their patience today. You guys are all great.
Can I have one of those 5 wishes for glitter? Of course.
Yeah.
Like one, two.
Ooh. I'm around here.
Table's very, like,
Table's very slippery.
Slippy slidey.
Grab a few and we'll pass it
Yeah.
around.
yeah, that's a good idea.
Somebody else said it, I can't take credit for it.
This is awesome.
Yes, sir. Thank you.
It is, and I need to make it so.
My name is there.
Oh, sorry, in my own world.
There we go.
I don't know how to get rid of the sidebar, so we're just gonna.
It's actually,
It's on 5 wishes.
showing 5 wishes.
You all are being great. Thank you very much, everybody. Well, we're a pretty great group here, I would say. Pretty relaxed about this kind of stuff. We are. What else are we gonna do?
No one's getting mad over it.
And I think when you were saying serious.
I wondered,
That's why she was like,
I was like, oh my goodness.
That's why I'm like, I'm putting that in there.
So for those of you who are not on or not here, somebody's phone, we think that Siri, hope she doesn't go off. It's like, yes, hello, when we're talking, which is pretty funny.
Yeah.
Everyone's, is this wishes?
It shows the sides are.
That's okay.
We're not gonna worry about it.
You know what?
No.
Fine. We're gonna make it work today.
Okay.
Yeah, I'm not touching it.
No. My name's Sarah DeSimone. I'm the Administrative Services Manager at Hospice Hospice, and this is.
I'm Shana Brady, and I'm a licensed master of social work at Hospice.
Yep. And, you know, we're so grateful to be here, and it's always a pleasure to hear, you know, another presentation on hospice and the services. We are a big proponent being with hospice in advocating for patients and families to talk about their end-of-life wishes ahead of time. It makes everything so much easier. So that's what our presentation is based upon. So we'll get started. It is end-of-life healthcare planning, critical conversations to have today to ensure that your wishes are known by families, by your family, and met by providers. It goes along with this 5 Wishes booklet, which we have a digital version of, scan of that can be shared, and we also keep physical copies of.
There it goes. Okay. So we plan for weddings, the birth of a child, college, and retirement. We spend months planning for vacations, and we plan every detail of every trip except the most important one we'll ever take. Some topics are much easier to talk about than others. Even families who dive right into arguments over money and politics can find themselves mute when someone brings up the topic we all need to consider. How do we feel about choices and care around the end of life? What do we want, and what are we worried about, and who will decide for us if we cannot?
Think for a moment, when you're on your final journey, do you want to live free of pain, at home, with loved ones caring for you? When you die may not be your choice, but how you live is.
So how do we make our wishes known? It's simple. We talk about it. We tell our loved ones what we want at the end of our life, And this will not only make you feel relieved, but it will also relieve your loved ones. Imagine having to guess what your loved ones want at the end of their life and not knowing if you made the right decision. See, when we make health decisions ahead of time and put those wishes in writing, we bring peace of mind to our families, and we enable our caregivers to advocate for us when we are unable to do so for ourselves. We are more likely to avoid the difficult situations that are so common when we become seriously ill and our loved ones are left to guess what we would have wanted.
Examine your own views. In today's world, there are many current events that serve the same function for us as a funeral of a family member, and they help us start conversations. But first, you have to examine your own views. It is honest and fair to explore your desires and fears about nearing the end of life and communicate with them with your family. Too often, adult children sit down with aging parents and want to make the parents face the hard issues. Say, it's time, Mom and Dad, but it will be much more effective if you do your own emotional homework first. There are many events and openings that can help get you started. If you want to be the conversation initiator, think about some of the issues and then watch for a good opportunity. You'll be surprised how many possibilities you may find.
So some conversation triggers, Jamie kind of touched on some of them, but some include the death of a friend or colleague, newspaper articles about illness and funerals, movies, sermons, television talk shows, dramas and comedies, financial planning, annual medical checkups, family occasions such as baptisms, marriages, and especially funerals, and magazines and books.
We'll go through some relatable talking points. We'll just do a little read through some examples. So for television programs, this is an example of a conversation that you might have when something comes up on TV. I know you saw the discussion last week on TV about the family who wanted to discontinue the feeding tube for the mother, but they couldn't because no one had signed the advance directive that was needed in that state. I thought that was terrible. What would you want if you were in a situation like that?
A death of a celebrity. I remember how much Paul McCartney loved his wife Linda and how he took care of her at home when she was dying of cancer. He had her family around her and her pets, and I think he even sang to her. That was so beautiful. When I die, I want to be cared for at home. I know it was easier for Paul because he has plenty of money, but I think anyone can help from the hospice group. So remember, I want you singing to me if I die, and I sure don't want to die in a hospital. Do you?
Newspaper articles. I've been thinking about those young people killed and injured on that bus accident. It's so heartbreaking when children die, and we just never expect it. It made me realize that you don't know what I want if I'm in a car accident, so I'm going to write it down. I'd like to talk with you about that and what you want.
Financial planning. I met with our lawyer last week to be sure that my will is up to date. I do this every 3 years just in case something has changed with me or with the tax laws. The lawyer reminded me that there will be medical decisions to make when I die, as well as financial decisions, and he asked me if I had given my doctor any instructions. I've been putting this off, but I know I need to decide. Can we talk about this? Have you thought about what you want? Will you be willing to take responsibility for decisions if I can't act for myself? And families differ. Some people value information and discussion and like to examine expert advice, and others, sharing an article in newspaper editorial might work. Every family is different.
But you can see if you watch for opportunities, you look for different opportunities, and most importantly, you just make it an ongoing discussion where you normalize it and you don't just, shun the conversation. You normalize it because it's just going to make everything so much easier. And studies show that most people with a serious life-limiting illness want to be at home with loved ones, free from pain and suffering, and in control of their care. The reality is that many people in their last year of life experience unwanted and often unnecessary hospitalizations. The majority of people, even those who are seriously ill, haven't talked about or documented their wishes. And many people are only referred to hospice services in the final hours or days of life, if they are ever.
So why does this happen? End of life is treated as a medical moment instead of a human experience, and people avoid talking about end of life. even if they do talk about it, very few people write down their wishes.
So how do we start this conversation? We normalize it. We will all face death at some point in our lives. Only 10% of us will die suddenly. The other 90% will be aware that we have most likely begun the final phase of our life. Hospice is there to provide guidance and support to those nearing their end-of-life journey. Why not? Why not choose to have the best death possible? Grief.
There you go.
Yeah, I said that.
Yeah, I think we're good.
We got it.
Thank you.
Maybe, there we go.
So we know and we understand that grief is going to, thank you, you did wonderful.
I'm a big girl now.
So grief is normal after a loved one passes, but complicated grief is not. When we leave our loved ones guessing our healthcare decisions, this can complicate the grieving process. And we've all seen it, the closest knit families, you know, that's when all of a sudden, one person was told one thing, another person believes another. Oh, geez, that can just, then you're left wondering, just like estates. Who did the right thing? Who did what they would have wanted? And it can, that's what the complicated grief from. Did I do the right thing? Am I doing the right thing? What are their wishes? There's no way to ask them anymore. So start the conversation and have it often. And Shayna will go into one of the tools we have.
So today we are sharing 5 wishes, which most of you here have the booklet. And as Sarah mentioned, we do have the digital version that will be sent along with the slides. So it is a 12-page booklet to help guide you in discussing personal, family, and spiritual matters in addition to medical and legal concerns. 5 Wishes is a valuable tool for beginning often difficult family discussions. When completed, it meets the legal requirements of most states, including New York. 5 Wishes deals with the things people say matter most to them. Each wish is based on a conversation. It allows you to clearly say what kind of treatment you want or don't want, so your family is not left to guess or second guess. This booklet is a starting point for these necessary conversations. You will read about many opportunities and ways to raise the issue. Once you realize how many conversation triggers there are in daily life, you will be ready to start your own conversation. And starting is the most important part. Too often these conversations don't take place until there's no time left for honest discussion, reflection, and planning. Having these conversations before the crisis is not only much easier, it is much more valuable. If you can begin to talk about the end of life while people are still healthy, you will have made a significant contribution to your family, and you will discover important information for yourself. Understanding family includes understanding hopes and fears around illness and dying. Conversations before the crisis help a family cope with inevitable loss. Preparing for death helps those who live on most of all.
So 5 Wishes, a few reasons why we recommend 5 Wishes, because it's easy to use, it's written in everyday language, promotes peace of mind for your family, it lets people know the care you wish to receive, and it also lets you express personal, emotional, and spiritual needs along with your medical wishes. Very important for hospice. As Jamie was saying, we care about your wishes, we care about your desires, and even though we are from different hospices, you can see that the hospice philosophy really carries over. I see a lot of the terms we say, do it before the crisis. You'll see a lot of that. So this not only will tell your family what you want, it clearly tells your doctor that there may be a time when comfort care is what you want. We know the medical field is treat, cure. What else can we do? What else can we do? Sometimes it does take the family to advocate and the patient to advocate and say, stop, break. Let me process what I want, let me share what I want. So if you can do it before the crisis, all the better, because it helps you be more prepared.
So conversation one, or wish number one, is the person you want to make healthcare decisions for you when you can't. And it can be found on page number 4 in your booklet if you want to follow along. This person is known as your healthcare agent. So choose someone who knows you very well, cares about you, and who can make difficult decisions. A spouse or a family member may not always be the best choice because they are too emotionally involved. Sometimes they are the best choice, and you would know best. Choose someone who is likely to be nearby so that they can help when you need them. And whether you choose a spouse, family member, or friend as your healthcare agent, make sure you talk about these wishes and be sure that this person agrees to respect and follow your wishes. And your healthcare agent should be at least 18 years old. And the 5 Wishes booklet also provides examples of who it should not be, and you can review those. But the good thing about already having this done and having it in your booklet is when you go to, your healthcare provider, if you're in the hospital, they're always wanting you to fill out your healthcare proxy. So if you do this already, you know who that person is, it's easier to fill out that form.
So conversation number 2 reviews the kind of medical treatment you want or don't want. It's on page 6, so we're moving straight through the booklet. It's going to cover instructions for pain control and life support. How comfortable do you want to be? Is some pain okay if that means your conscience is able to talk to your loved ones? Or would you rather be medicated more if it means that you will not experience any pain at all? It allows for different wishes in different situations. Different examples of life support are provided. So this does get into the nitty-gritty, difficult conversations that doesn't come up in everyday life, but go through it and go through it ahead of time, and you won't. It's going to be easier. It's stuff that might not come up in the earlier conversations. So, do you want life support no matter what? Do you want life support if your doctor believes it could help? Do you not want to be on life support? There's a few different scenarios. If you're in a coma, if there's other life-threatening conditions with these options, there's some things pre-filled out, so you can just easily check the box, yes or no, and there's also space for you to write instructions based on personal beliefs.
So conversation 3, or wish 3, is on page 8, and it's how comfortable do you want to be? This conversation allows you to express your choice for types of comfort care and allows you to cross out or keep items based on your choices. Some choices include, I wish to have my favorite music played as much as possible until the time of my death. I wish to have warm baths often. I wish to be kept fresh and clean at all times. If I show signs of depression, nausea, shortness of breath, or hallucinations, I want my caregivers to do whatever they can to help me. And these are just starts, it's something that, the great thing about it is it can be tailored to you or your loved one completely, and it's also something that can be filled out anytime, even, it's something to have now, ahead of time before you experience any of this. Amen at it. There we go.
So conversation 4, how do you want people to treat you? This includes things your caregivers and family should know about how to support you, including if you wish to pass at home. In addition, it can include the types of things people can do for you, including prayers, visits, placing pictures of families in your room, holding your hand. You can cross anything out that you do not agree with, and you can add anything in that you like.
And that's okay, we can do that. Yeah, you just get rid of the old copies.
So conversation 5 is on page 9. What you want your loved ones to know as you near the end of your life, or how you want to be remembered. This last section encourages you to express matters of deep importance. Special messages from the heart to friends and family. Offer love and forgiveness to those who have hurt you. Communicate practical matters such as preferences for memorial or burial. You may choose to attach a note or a page or a letter to an individual. All of that is fine to do, but 5 Wishes is set up so that even if you don't want to go to that level, you can still convey a general sense of what you want your loved ones to know. That general sense of love and forgiveness is often one of the most important things people want to convey that sometimes just doesn't happen because we are distracted by so much else. The clinical side of things, the logistics, or we just get to the point where we are no longer able to speak for ourselves. That is where this comes in handy, to relay what may be at the top of your mind or on the top of your heart to convey.
Once you've completed and documented your wishes in your copy of the booklet, don't just file it away. You can follow the instructions on page 10 in the presence of a witness. In New York, a notary is not required. Photocopy and give it to your healthcare agent, doctor, family, and friends, and keep the original accessible, not in a bank box or safe. Discuss your wishes with them too. We encourage you to take time now. Remember, planning and sharing your wishes may someday make an incredible difference to you and your loved ones.
And that's a great thing too about 5 wishes is I know for hospice we want a most form. So you'll have to
Medical orders for
life-sustaining treatment. There we go. So that can all be taken right out of 5 wishes. So you've already had these difficult conversations, you've already decided what you want, and now to fill that out is much easier because you've done all of this work. So at High Peaks Hospice, our agency's goal is to get people to discuss their healthcare wishes ahead of time. Everyone will face death. Why not ensure it will be the best journey possible for you and your loved ones? And let's take a moment to discuss the main philosophy of hospice, which we have kind of done already, but we'll do a brief kind of review and ways we can support those facing a terminal illness.
So this message sums hospice care up nicely. It's very close to the one that Jamie shared. Hospice adds life to your days when you can no longer add days to your life. Hospice care solely focuses on comfort and quality of life.
So at High Peaks Hospice, we have our Circle of Care team, similar to community hospice, which the patient is in the center of that, and our team includes hospice physicians, RNs, LPNs, social workers, spiritual care coordinators, and trained volunteers. And it is important to realize that the primary care doctor is also in there, so when patients come onto hospice, they get to keep their primary care provider. That's, I know, sometimes a very important thing for a lot of our patients because they've been with that person for years.
Our specialized care for the terminally ill helps the whole family. Patients will receive emotional and spiritual support and state-of-the-art medical care tailored to their wishes. It's usually our pain management, the symptoms that come with a terminal illness. You can think of us as specialists in that field. But for families, hospice care also eases the burden of caregiving through teaching and assistance with care. We'll teach people how to safely transfer, how to give medications, what to expect, what's normal, what's not. Those are some of the most important things in giving them a person to call. But they also get the emotional and spiritual support. They get respite from our trained volunteers that will go into the home so they feel comfortable to go to the salon, go do a shopping trip, go for a walk. Without hospice, sometimes they don't have that. If something comes, they don't have to go to the emergency room, call an ambulance. They have us to call 24 hours a day, 7 days a week, and listen, talk, do a video. Does someone need to come out? So, and our social workers help with resources or referrals for other challenges that a family may face.
I think one of the biggest things you were touching on it about the ambulance and stuff. I know for me, when I was working in the homes, when a patient would pass, there's no police, there's no ambulance. It's just us that comes out, and then we make the phone call to the funeral home, and the family can determine how much time they want to spend with their loved one until the funeral home comes and kind of takes them.
Yep. If you have religious beliefs, that's some ritual that you want to follow, if you want to be a certain outfit, and time, and not having the lights and the sirens. It's very peaceful. It can be very calming. And sometimes you don't realize without hospice and without it being an attended death, that is actually, it's required, and it's all too often that happens. So it's one of those things that
People might not know.
People may not know.
So as Jamie mentioned, hospice care is provided anywhere that a patient calls home. So primarily it's in their own home, but it can be, as you see on the screen, in other places as well.
And it is a wide range of services. It's all focused on enhancing their overall quality of life. It can include everything from dietary counseling, prescription drugs, DME, equipment, supplies, medications. These are all in addition to what we hear time and time again is our most invaluable service, and that's helping families and patients feel connected, supported, and not alone, no matter what time, day or night it is, when a panic or emergencies arise.
The criteria, again, is anyone with a diagnosis of 6 months or less. And this is any individual. We have had patients under 18 on hospice. The only difference for when somebody's under 18 is they are still able to pursue curative treatments as well while being on hospice. That's the only difference.
So, like I said, in our general hospice presentation, we're titled A Benefit Every Family Deserves, because that's what it is. It is an insurance benefit. It's a Medicare benefit. If you've ever worked a job and you see the Medicare, there's so many things that you don't, you pay into that you almost don't take advantage of, and this is one that far too many people have available, and that's where the funds come from Medicare, is from those deductions. So it truly is a benefit everybody deserves. But Medicare has it, Medicaid, most private insurances, and HMOs, same with community hospice. Where do funds come from? Someone doesn't have insurance, they're not of age to get Medicare, they're not on Medicaid, community support. We get donations and things. And the community support helps a lot. It helps our whole bereavement program, which is not funded from any of those carriers. And it helps for just equipment, supplies, and that are surpassed on transportation to and from the hospital when we take people home where they do have a fall, like where it's a abrupt, injury and they do need to go to the hospital. That will be covered, and it will not be reimbursed to hospice from the insurance carrier. It will be covered through community support that we receive, that we have a fund for.
And to touch on this again, anyone can make a referral to hospice. It can be your personal physician, nurses, friends and neighbors, the patient themselves, or a family member. I know that we have seen it a lot where sometimes a personal physician has a hard time making that call. They've been working with somebody so long and they can't see the writing on the wall, so to speak. And sometimes the friends or family or the patient themselves has to really advocate, and just calling. I mean, we have Tracy in the Glen Falls office, or Hudson Falls office now, and then Emily in the Mineville office, who are absolutely wonderful, and just calling and talking to them. And we do informationals at your home. We can go to the hospital to do them, friend's home, wherever, over the phone, and it's not signing on to anything. It's just kind of getting an overall informational for kind of what hospice is.
But people who we've had on service longer, we've gotten to do some very special things with. So we'd like to share some examples of things we've gotten to support patients with. Once we coordinated a canoe trip for an outdoor lover. We had a doctor and a patient. They were both fiddlers, and they really enjoyed playing music together. A gentleman who had recently built a house just before an aggressive diagnosis got to fulfill his wishes to go home and host bonfires. We've assisted patients in writing their memoirs. We've coordinated a patient in attending a NASCAR race. And we've coordinated wishes to make it, this is very common, make it to family get-togethers, attend milestones of their loved ones. And many, many times, hospice is the support that families need, and often that the hospital requires to leave the hospital and get back to where they want to be, their home.
And we work with other hospices like Community Hospice. We have a lot of snowbirds around, and we have a lot of people that come up into our area for the summer, and we work with, let's say they were on a hospice in Florida, we work with that hospice while they're here to make sure that if they have any issues, we're here to help them. I know, I had a patient who went to Maine while they were on service, and we worked with the hospice there to make sure they had their oxygen there if they needed a hospital bed. But more specifically, they had somebody to call in the middle of the night if anything happened or if they needed that extra support. And every hospice experience is unique, but the one thing families tell us at High Peaks Hospice as well is that they wish they had called sooner. They refer to our care team as angels, and they share how much we were there for them both physically and emotionally. And they share how we made such a difficult time so much easier. And I'm sure a lot of people here also have experienced hospice and can attest to, you know, how helpful it has been to them and their families.
So as we come to the conclusion, we just want you to remember that we are here to support you. We are just never too early to learn about hospice and palliative care as well. We are so thankful that, in this day of age, hospice is inherently palliative care. Hospice is palliative care, but we're so happy that more and more services are becoming available where they're working in, just like that chart she showed you, that was wonderful, how they're building in, so you get more and more support as you get closer. Not all palliative care programs are not nearly as covered as hospice is, but it's still great that they're available. So we partner with local hospitals, nursing homes, schools, and funeral homes to be a resource to the community. Our goal is to help achieve a better quality end of life and a peaceful passing. And we offer the no-cost bereavement support and programs to anyone in the community who needs it, including children. So even if you have a loved one that passed, they never used hospice, many hospice programs, including us, we have a bereavement program. You can call us for any kind of grief support. We do many different services and groups and sessions. And that we're just a phone call away. We want people to know that you can call us directly.
Awesome. And then there's a comment in the chat. So throughout the discussion, I keep thinking about the amazing book. It's called Death is But a Dream by Dr. Christopher Kerr. It's such a touching book. I think it could be a great resource to really help all understand end-of-life experience and spark some meaningful discussion.
Thank you. That's awesome.
Thank you.
All right. Thank you very much for that, for High Peaks Hospice. Thank you for that. Next, give us a second here as we transition. Our next presenter is Barbara Price. So, and you all on your end might be, we're trying to figure it all out here, so please give us just a second. So her, right? No, hang on a minute here. So it looks like you got two actual screens here instead of. Yes, it is. I have no idea.
Yeah, I'm going to say something about a do not resuscitate bracelet. Yeah. Is that something that you offer? Do you have bracelets there?
We do not.
Okay.
That's a great thing.
Written here, do you have a do not resuscitate form or bracelet? Okay.
I would assume, I'm just guessing, my husband has a tree nut allergy, and I know you can get the bracelets off Amazon, so I'm assuming they probably have those. That is a great idea, though.
So, Barbara, good morning. What I'm going to do here is, in just a moment, I'm going to make you, I got to change the view for the people here, and you're wonderful, thank you. That's not who we want Barbara. But once I mute me, we're gonna be able to see Barbara. So good morning, Barbara. I'm gonna mute me and let you take it away.
Thank you. Okay, you ready? Okay, I did not prepare a slide, PowerPoint. I'll work on that. It might be something for the future. I'll introduce myself. I'm Barbara Price. I'm a private practice, board certified patient advocate. I'm an end-of-life doula, and I'm also a community hospice volunteer in Washington County. I want to thank Jamie, Sarah, and Shana for the foundation, the exploration of the foundations of end-of-life care and planning, because that work informs and has influenced the rise of the end-of-life doula role that I want to tell you a little bit about today. And so I'll just do an overview of the end-of-life doula. It's really the who, what, where, and how of this kind of role. And you'll notice as I'm talking to you, I'm just going to scroll a little bit, that a lot of the things I mentioned are also addressed in the care that hospice does, overlaps a bit with palliative care, in my mind, very much with palliative care in terms of addressing suffering. And many of the subjects that we talk about as an end-of-life doula are really covered in 5 wishes as well. So there's a lot of overlap in terms of the roles and tasks of the job. End-of-life doulas are non-clinical, non-medical companions and guides. Even when an end-of-life doula has a nursing license in their role of doula, they are not permitted to provide medical care. And I'll just mention that I'm going to say doula to shorten this. We won't say end-of-life doula each time. When I say doula, I mean end-of-life doula, not birth doula. The doula is there to address suffering, to enhance the quality of life for the patient and the family and the loved ones, to work collaboratively with palliative care, hospice, and the whole medical team, to support conversations about goals, hopes, and plans. So as we were saying, what are the plans? What are those longer term plans, and how early can we start? They're trying to bring peace of mind and comfort in whatever setting. Any end-of-life doulas work in every setting wherever the patient resides. They act as advocates and are an extension of the care team. I'm just going to take a moment and ask you a question. How many people here today have talked about or written down their wishes for end-of-life care? Could you just raise your hands and use the little icon for raising hands? I just got to see how many I get. Not surprising, not surprising. Because when we're young, we're not thinking about it and we think we have time. This is not just about aging. It's not just about critical illness. It can be emergencies, it can be accidents. So I encourage everyone to consider those things, to think about them, talk about them, write them down, and then document it in an official way, like with 5 wishes. So that's me being a doula for you. Some of this is a repeat. End-of-life doulas provide physical, emotional, spiritual, and practical support to the dying person and to the family. They nurture, inform, guide, empower, and comfort. And in many ways, given that opportunity, and I'll talk a little bit more about the model for community care, they can be the project manager in a way that helps coordinate the intimate care and the peripheral care of all the people who might be there to help with house cleaning, shopping, cooking, laundry, all the extensions of care that make it possible to die at home. And these things, as both teams have said, hospice cannot provide that 24-hour care and that kind of intimate, total care. So we do need a plan for who is going to provide that care. Is there enough family? Are the friends and neighbor team a coherent team? And how does that get pulled together? And the doula can fill that role. Let me mention how doulas are trained and licensed. Many doulas, most doulas I would say, are formally trained. They have taken oftentimes an online course. There are some in-person courses. Many are self-taught in a way, that we come to it because we have been practicing compassionate care in the work that we've done throughout our careers. And we add the end-of-life doula aspect as another dimension of the caregiving that we can bring. And there are many, as the interest in the field grows, there are many more programs being offered online and in person. I'll say that end-of-life doula training receives a certificate of completion. It is not a certified role. There is no board certification. There is no centralized exam for licensing, and there is no licensing board. The cost of training is kind of, can be of interest to people. The programs will range from about 6 weeks to a full semester. The price range is about $300 to $1,000 to do one of these programs, where you might attend a credentialed, accredited university program where the tuition would be higher, and particularly true if you're doing it through a graduate program. The coursework will include, I won't be too specific here, ethics, physiology of aging and dying, and communication skills. That's really the core of it, and there's a lot more around it as well. And there is a code of ethics that delineates those ethical responsibilities, what we can and cannot and should not do. And I'll tell you a bit more about those organizations. What I feel, from my own perspective, the end-of-life doula should be committed to and have a deep understanding of what it means to be compassionate, and a strong desire to be present and a support during end of life. Anyone who comes from a heart-centered place can do this work. So the doula care, the doula model of care involves a non-medical and non-judgmental support. It involves planning ahead before the crisis. It's a family-centered, holistic care approach. It empowers informed decision-making and self-determination. And it's a role within a team of care providers. The organizations that kind of, I wouldn't say supervise, but organizations for doulas. There are a few member-based organizations. There are two that I want to mention today, INELDA and NEDA. INELDA is the International End-of-Life Doula Association. They have regular online and in-person trainings. They kind of are a gold standard for the online trainings. They have membership and member directories, continuing education, regular Zoom community meetings, and they are a major lobbyist with a public education outreach. The National End-of-Life Alliance, NEDA, listed 1,550 doulas in their registry for 2024. They established the practice guidelines. They have extensive information for doula practice and for the families seeking doulas. They provide a proficiency certification and directory for training around the world, as well as how to find a doula. I'll stop here for a moment just because I'm talking and talking, no video. What, are there any questions yet? I'll go on. What are the skills and training that a doula should have? What should a family looking for a doula consider when they are thinking about the person who's going to come into their home? So beyond the curriculum are all the soft skills: presence, being a good listener, a witness, a calming influence, providing emotional support, and always staying in the doula role. It's information sharing, providing education as needed, especially about the process of dying, so that the family, as well as the person who is going through the death process, understands what they can expect. It's not always predictable, as we know, but there are stages that we do observe and can be helpful to know they're coming. End-of-life doulas provide proactive guidance. We're looking ahead, we're anticipating the needs, and helping the families make a plan. We're considering comfort measures and the physical supports. What hands-on techniques or help with positioning, visualization, use of breath, other complementary care might bring more comfort to the person who's dying. Where do doulas work? They work wherever people reside. They are more and more working with hospice teams as volunteers. Some hospices are bringing in doulas as a member of the team, and some hospices are training their volunteers in end-of-life doula skills so they can provide them from within the organization. INELDA is bringing end-of-life care to people, to unhoused, people without housing. It's one of their missions to reach well beyond what we usually think of as homes and where care can be provided. Other organizations are training the incarcerated to provide end-of-life care in prisons, where that's an essential, it's a very moving concept to me, and a really necessary. So end-of-life doulas can be care providers, lobbyists, advocates, educators, comfort bringers, and team coordinators. And I think that end-of-life doulas gravitate toward the roles that they are innately best suited to. The combination of skills and their own qualities and characteristics guide what are the services they're going to provide. One thing I didn't mention before is that end-of-life doula work is not covered by insurance or Medicare or Medicaid. It's all private pay. And many doulas, including myself, do a great deal of pro bono work. I feel like this work that everyone deserves, as everyone has already said, everyone deserves caring at end of life. Everyone deserves comfort. No one should be excluded based on finances or where they live. So I think we've kind of covered, I have a question here for myself, why hire a doula? What exactly do doulas do? They can create a care team. That's something I hadn't mentioned, and I'll mention a little bit more at the end of this. They help people navigate end of life. They are a companion, a guide, a mentor. They can be a reliable and dependable friend to the person who's dying and to the family. They help with the education about the dying process, and they make sure the dying person's wishes are honored. End-of-life doulas with additional training can support VSED, voluntary stopping eating and drinking. They can support accessing medical aid in dying. They can support pediatric patients and families. With good training, they can support the dying who are experiencing, also have mental illness issues, developmentally disabled adults, families with a family member with dementia. They can also provide ritual care for the body after death, and they provide funeral services and memorial services. Even at end of life, we are still evolving as human beings. And this is a period that can offer an opportunity for reflection, to resolve feelings, address unfinished relationships, consider regrets, and connect with loved ones. I like what the psychologist and author Ira Byock wrote in 4 Things that Matter Most. We sum up our lives with 5 final tasks, saying, I love you, thank you, please forgive me, I forgive you, and goodbye. And I feel that the end-of-life doula role, very much in the essence of it, is there to support those 5 statements. If you were looking to hire or to talk with an end-of-life doula, how would you find them? I would suggest the end-of-life, the directories, the online directories for INELDA and for NIDA. You might have it through word of mouth. We have regional care provider networks, in which do have end-of-life doulas listed there. Facebook groups which can be remarkably helpful in finding those people. And sometimes health providers or service teams can do it. I think my experience thus far is that they are not as familiar with the work of doulas, so they may not be the greatest resource just yet. What does a doula cost? The hourly rate can range from $25 to $100. Some of them offer packages. Many offer pro bono work, and sliding scale. But that 25 to 100 kind of gives us that sliding scale. But because the pace of dying is unpredictable, it's hard to say how much a family might be investing in having an end-of-life doula. They might choose to work with someone at the beginning to get the plans in place, to work through what are the goals, what do we want to avoid. And some doulas offer packages in the entirety of the process for you. And I don't know how that would influence the amount of time they have, because that is one of the things that doulas do provide that hospice can't, which is they have time. They spend more time. They can come more frequently and be a different kind of presence in the lives of the family. I think hospice and doulas are both in part responding to that increased medicalization of death, and to what we see as I don't know whether it's still increasing, but kind of that futile medical treatments at end of life, the degree to which medical interventions are happening at end of life. As professionals, we know that none of us can do this alone. We need our team. We need a trusted and trained team. I think the work of dying also needs that team. We can all support dying at home through a compassionate community care model. And I think hospice, it fits into that very beautifully, but there's another way of thinking about it. Educator, consultant, and end-of-life doula, Dr. Annetta Mallon, published an article in a palliative care journal entitled Compassionate Community Structure and Function, a standardized micro model for end-of-life doulas and community members supporting those who wish to die at home. And her theory is that we need 14 people around us to die at home with no one experiencing burnout and creating the best possible comfort. In her paper, published in 2021, she identified 3 roles for end-of-life care: the intimate, the gatekeeper, and the peripheral. And they're all essential to function effectively. The intimate providers may be the family or loved ones already. They work most closely with the dying person. And it's the fewest people. It's the middle of the circle of care. The gatekeeper or gatekeepers manage information sharing, organization, coordinating care, and that may be 1 or 2 people. And then what she calls peripheral, which is, I'm almost uncomfortable with that as a concept, but I don't have a replacement for it. Those people are fulfilling the tasks and routines of the household, the shopping, the laundry, all of the general supports that make it possible for the intimate and the dying person to stay connected and present. And that peripheral group is the bulk of the 14. And I see this model as a flexible floating team. It's based on whoever's already providing care. It expands locally to those trained or training in end-of-life care. And it includes all of us: end-of-life doulas, home health aides, nurses and social workers, all of the hospice and palliative care team. It may involve the EMTs, chaplains, someone from their religious organization. It may be energy work, massage, music, whoever is in the community, whoever can provide that extra care, whatever the dying person might want. So together, and we are the community, but we cohere, we create this small team that can come in and be present in whatever way the family needs. Now, I said a lot. I'll say thank you for listening to that, and I'll have images next time. And if you want some detailed notes, or you want any of the source materials, or to contact me about patient advocacy or end-of-life doula work, you're free to email me or call me. But I'll open it to questions if you have any.
Thank you, Barbara. And for everybody, we will send contact information in with the notes, as well as any further information that Barbara might find pertinent. And we really appreciate your time here today. Thank you, Barbara.
Yes, thank you.
You're welcome. Thank you for having me here.
And last on our agenda, certainly, we chose, the issues of declining health and, death and dying, because we ourselves, as professionals, have seen that it is in the best interest of everyone involved if those discussions are being had earlier, right? We see that a lot, and we as professionals, those of us here who are attending as professionals, often will see when we wish that hospice had been called earlier, because it's very difficult to support them in their wishes, because they kind of weren't discussed early enough. But another piece that we often hear as professionals, and it is also just, feedback that we receive from members of the Long-Term Care Council as far as, future ideas or things that we really need to discuss, is that, there are times, and I mean, I am the nurse evaluator for 2 programs in the community that, to provide community support and care. But there are times when home is, for a myriad of reasons, and I feel like we need to kind of take the judgment out of that, that home is not the right place. It's not a safe place. It's not a healthy place. And their needs will not be met at home. That just sometimes, for many, many reasons that don't require speculation or judgment, is not the right place for them to be. And so, for a person, a facility may be the safest, healthiest, best option for them. And I think that certainly can be a scary and difficult conversation to have with people. So I feel like one of the important things to highlight is the Ombudsman program. I feel like, a lot of what we hear sometimes as the nurse evaluator, that we try to make that not, be so. But even in my line of work, there are times when I am the person possibly having that conversation with someone that home is not, it's not right. It's not healthy. It's not safe for you. We are unable to find, a network of support or the level of a person's medical need may surpass truly what is available in the community. I mean, that can be a reality. So one of the things that were really, really important, and I feel like it's an important conversation to have and to get that message out there earlier, is the Long-Term Care Ombudsman program, because one of the biggest things we hear is people are afraid that they won't have decisions. They won't be able to verbalize what they want if they have to go into a facility, formal entity. How do I, no one's going to listen. I'm not going to be able to say what I need to say. And that is the role of the Long-Term Care Ombudsman. So I'm going to turn it over here to Mary from the Ombudsman program to talk about what the program does, the fact that it is resident-centered. It encourages and teaches residents self-empowerment, what their rights are, how they can resolve concerns. Going to talk about some of what those typical concerns might be, and is going to provide us all an education on how to choose, ways that they can help, if you're looking for a facility, and how to do and how to navigate all of those things. So, Mary, welcome this morning, and I'm going to move this closer to her for all y'all. And take it away, Mary.
Thank you. Good morning. My name is Mary Kennery. I'm the Program Director for the Regional Long-Term Care Ombudsman Program. We do cover Washington, Warren, and Hamilton counties. In addition to that, we do have the capital region surrounding Albany and Fulton and Montgomery counties as well. It's that.
Or maybe we gotta do it a different way.
We can do it another way. If that's...
There it goes. Okay.
So just briefly, where does the Ombudsman program come from? This is a program that was created by the Older Americans Act of 1972. It is a federally mandated program operating in all states. We receive federal and mostly state funding in New York State. Oversight for our regional program is provided by the New York State Ombudsman. She is an appointee named Claudette Royal, and that is housed in the New York State Office for Aging. Statewide, there are 15 regional programs. What is an ombudsman? An ombudsman is a resident advocate. So an ombudsman is basically a Swedish word. It comes from the Swedish. It means sometimes it can be a trained volunteer, but more centrally, it is an independent advocate for residents of nursing and adult homes, a problem solver, a protector of residents' rights, and a friend. So we work to resolve problems that are related to the health, safety, welfare, and rights of individuals living in long-term care facilities, nursing homes, assisted living programs, and also family-type homes in New York State. We try to promote policies and consumer protections as well to improve long-term care services and supports at different levels. So you can see here some of our roles. In addition to being an advocate, we also can act as mediators or negotiators, and just basically an all-around problem solver. Regionally, our program is hosted by Catholic Charities Tri-County, and this is our territory, our geographic region. In our region, there are 44 skilled nursing facilities, 50 assisted living facilities, and about 20 family-type homes. That covers roughly 10,000 long-term care beds. Currently, with staffing being what it is in our region and certainly nationally, not all beds in all facilities are filled. There are many places in our region that currently have whole units or wings of facilities shut down for inability to fully staff. So roughly 10,000, I suppose, is the maximum number. It's currently much, I would say, less than that. Our logo. Federal law. By federal law, all facilities have to give us access to residents 24/7, and we also have access to resident records with their consent. We are HIPAA exempt. That just means we only need residents' verbal permission to look at their records. We have 7 staff members and roughly 16 volunteers. It kind of changes month to month sometimes, but we do have a core of volunteers as well as staff certified, New York State certified ombudsmen who work to investigate residents' concerns and complaints and try to resolve those complaints within the facility. Our volunteers, our state-certified volunteer ombudsmen, agree to spend 2 to 4 hours per week at an assigned facility. They visit residents, they make themselves available to help address concerns, and all staff and volunteers undergo a 34-hour certification training, and they also attend an hour or 2 of monthly in-service continuing education. We all are required to document our complaints. I can tell you a little bit more about that, but that documentation is entered into a statewide database. And that statewide database is really, really helpful for me at the regional programmatic level to monitor trends of types of complaints, whether it's in a given facility or regionally. These are some of our roles. As I mentioned earlier, we can be negotiators and mediators. We also are educators in residents' rights, and we investigate complaints. So one of our core values is that we are resident-focused. We can only act with the permission of the resident. The resident is always our client. All of our communications with residents are confidential, and we have to obtain consent to use the resident's name when we investigate with the facility. We always work with the resident, regardless of whether there's a healthcare proxy or power of attorney. We are resident-centered at all times. So the resident is always the first person with whom an ombudsman must discuss complaints or concerns, and they are the focus. So what that translates into basically is that anybody can call a complaint into our office from around the region regarding a long-term care facility, a nursing home or assisted living program. Could be staff, can be family members, can be a concerned person in the community. Sometimes EMTs call us, fire department. It can run the gamut. But ultimately, once we, receive a complaint, it is the resident that we go to speak with, and the resident directs our next actions. So sometimes family members can, will say to us, oh, these are the things that are going wrong, and, with my mother's care. And, we tell them a little about the program, and sometimes the family member will say, well, my mother has dementia, and so, I would like you to, follow up on this. So we say, fine, we appreciate that. We appreciate the person reaching out. We take it very seriously. We will still visit the resident, regardless of any cognitive impairments or any disabilities that the resident might have. We still always start with the resident. And, that is because even a resident with cognitive impairments may be able to express their preferences regarding, certain or any aspect of their care. Certainly a resident with dementia might be able to say, yeah, my food is cold, or, yeah, they are not changing me. I'm sitting in a wet, depends. We still defer to the resident. Sometimes a family member might say, oh, they're not going to tell you what's going on. Well, it comes down to the resident's wishes. The resident is the person living there. So they might say, yeah, that's true, that's happening, but I don't want you to do anything. We will run through some resolution scenarios with the resident. We'll say, these are your rights, and we'll try to empower them to act on their own in the first instance. We'll say, would you like some help in trying to resolve this? Our suggestion would be that you talk to the nurse manager. We can offer to kind of broker a meeting with the nurse manager or with the social worker, someone in the facility that can help them. How would it be if we bring the nurse manager down and we have a little discussion right here, right now? How would that be? Would you like that to happen? And I'll be here present to support you, and you can describe to her what's going on. And we can propose, like based on other cases we've worked on, other complaints we've handled, what might be the good direction to go in? What can we tell the facility about what our expectations are for this resident's experience going forward? So the resident is really in the driver's seat, and it all depends on them. Now, sometimes a resident might say, yeah, this aide really treats me very roughly, and, you know, they're insulting to me, you know, they're not respectful. But I don't want you to do anything. So that can happen. We're not mandated reporters as ombudsmen. We have to leave it there, but there are options that we have if we hear something like that. So we take it very seriously. We don't leave it right there. There are things we can do. We can investigate something anonymously or as an ombudsman. So we can walk around the unit and say, you know, so maybe this resident says, yeah, you know, that particular aide on the day shift, she's very rough. So we can kind of take a walk around and say, hey, the different residents, how are the aides treating you? You know, are they respectful? How are things going? So we can get a little bit more resident input, and maybe someone would say, yeah, you know, there's something I want you to do about that. Or even if multiple residents say, yeah, you know, that particular aide is very rough with us, then I have enough to go on that I can proceed and have an ombudsman complaint and go to the facility and say, okay, you know, this is a problem, this needs to be resolved, and we hold the facility accountable. The facilities under the law must cooperate with us. Now, some facilities are a little bit more cooperative than others. Sometimes we have to kind of chase people down a little bit. Sometimes some facilities are, you know, bend over backwards as they tell us what's going on, how can we make it right. We see a whole range of, you know, cooperation. That's okay. We're trained to deal with it. So if they dodge us a little bit, if they avoid us a little bit, we know what to do. We can take it to another level if we need to. One contrast that I'd like to make is, so we are not the Department of Health. So the Department of Health is responsible for surveying facilities for compliance with nursing home regulations, and they have the ability to fine a long-term care facility for not being in compliance with nursing home regulations. They can give them a citation for deficiencies. We do not have that power, but facilities know they do have to cooperate with us. So we do have a mechanism under a 2021 law that was passed in the legislature in the wake of the nursing home problems in the pandemic. The New York State Legislature did pass a number of reform measures, and one of them was that the Ombudsman now has a mechanism for us to complain to the Department of the Health from our office if we make every effort to resolve something and the facility is just not doing what they said they were going to do, or they're not cooperating. We can go to the Department of Health on our own, and the Department of Health has a different kind of avenue for responding to ombudsman complaints, and so we can escalate things that way. So we are also involved in Department of Health surveys. When the Department of Health goes into a facility, they will contact us and say, hey, you know, we're at Granville Center, what is your input? And we do have a staff member who visits Granville Center very frequently, and she will have a whole list of notes on what she observes in the facility as well as resident input. So she will be able to say to the Department of Health, yeah, these are the problems that we have seen. And then we are a part of their exit conference. So when the Department of Health hands down those deficiencies at the end of their survey week, we participate in that so we know exactly what is going on in that facility. Here are some resident rights. So did you know that as a long-term care resident, you have more and different rights than you do as a member of the community? So of course, as a member of the community, we all have our constitutional rights, we all have basic rights and freedoms, but these are additional rights that someone has when they become a member, a resident of a long-term care facility: to be treated with dignity and respect, to manage your own finances, to voice grievances without fear of retaliation, to communicate privately, to be informed of rights, services available, and charges, to be provided with advance notice of transfer or discharge, to be clothed appropriately for the time of day, and to refuse treatment or care. So common complaints that we handle, that we work with, it's a very wide spectrum. Each resident is unique and has their own life story and their own voice. So every complaint that we receive is as unique as the residents we see. But, you know, in the aggregate, these are some of the common complaints that we work with. And if you have had a loved one in a facility, I'm sure, you know, a lot of these will be familiar to you. So when we receive a referral into our office, we will visit the resident and we try to engage the resident in conversation to identify what the problems are. And then after we resolve the complaint, you know, with a little investigation and a you know, meeting with the facility, we continue to check in with the resident to make sure that the resolution is going the way that we had expected or the way the facility had committed to, and to make sure the resident is satisfied. So one other aspect of our program, in addition to visiting residents to follow up on complaints, we are obligated under you know, the state ombudsman's, you know, policies and procedures to visit all 100 of our facilities at least once a quarter. And with recent increases in staffing in our program, with increased funding from the legislature, we also visit facilities more frequently than once a quarter. Many of them are monthly. Many, we have high complaint facilities where we're concerned about situations where I will ask a staff member, please visit this place weekly or bi-weekly. So we are obligated to make routine visits where we lay eyes on the facility. We look at red flags. We try to introduce ourselves to as many residents as possible. We attend resident council meetings. We also attend family council meetings. And we just, you know, try to kind of get a view of what is happening at least once a quarter, many places more frequently than that. So based on our visits, you know, I have a few slides basically on how to choose a nursing home. So during COVID, tours were not possible. People were Zooming to try to show people, or FaceTiming to show people a little bit of an idea of a facility, but we still recommend try to take a tour right off the bat, and what you should be looking for. So cleanliness, that will jump right out at you. How are staff interacting with the residents? How does that seem to you? Are there some outdoor spaces? Is there memory care? And then take a look at how the residents look and the time of day. So when we visit, if we're visiting in the late morning and we see residents still in bed, that is a red flag for us. If we see residents in bed, you know, in the afternoon, I mean, granted, some residents might want to take a nap, but if they're in a gown and they're not groomed for the day at a certain hour, that's a red flag, right? Are there shared or private rooms? Some people want a private room. Is there a lounge where residents can entertain visitors? How does therapy equipment look? Does it look to be in good condition? So there should be activities offered. Usually a calendar should be posted. Other aspects to consider, ownership groups. Sometimes there are some owners in New York State who have some problems right now. So that might be something to consider. Some facilities have religious affiliations. So in our region, we do have Catholic and we do have Jewish religiously affiliated facilities. What are the visiting hours? Physicians, physical therapy. How about weekend staff coverage, activities, quality of food, family reviews, proximity to home and family. Something other something the public might not be aware of is that facilities have to post their staffing every single day with the census. That is supposed to be visibly posted, like in the reception area every single day, with the number of RNs, LPNs, and CNAs on duty with the census number every single day. So take a look at that number. It's not always the easiest to interpret, but you can say to them, hey, on this, on the rehab unit, how many CNAs are working today? That is a good number to know. I would encourage you to look at that. Some local resources for comparing nursing homes. The Albany Guardian Society puts out a booklet called Housing Options for Senior Adults in the Capital Region. I don't know that they include Warren and Washington. They do include Saratoga County. There are ratings that you can look at online. So the Centers for Medicare and Medicaid Services. So as you know, Medicare and Medicaid is the primary payer for a nursing home stay. Very few people can afford a nursing home private pay. So the Centers for Medicare and Medicaid Services certify facilities to receive Medicaid as payment. So they compile a rating system. They have a 1 to 5 star rating scale. It's not our favorite rating. The hospitals, when someone is ready for rehab, they will give people this rating scale for local facilities. We don't think it's totally the best snapshot, because sometimes we see facilities that have 1 star that are actually pretty good, and then we'll see other stars that have like 4 stars that we think, we're not sure about that. So I think what's going on there is the timeliness of the data, is a delay in reporting sometimes, but this is what it encapsulates: health inspections, staffing, quality of resident care. It's also only available in English, so there are some drawbacks, but it's a good starting point. So that's where you find that. You go to Nursing Home Compare. I think a better way to look at ratings is to go to the New York State Department of Health Nursing Home Profiles. You go to Profiles at health.newyork.gov, nursing home. You click on the New York State map. It'll zoom right into facilities. And it also has a star rating. But what we like here is that you can see the Department of Health's deficiency and listing, and you can see really, are there repeated deficiencies? That means they have not cleaned up their act even after receiving a citation. Or was there harm? Was there abuse? That would be something to jump out at you. And that also shows staffing numbers. A great advocacy group in New York State, actually they're national as well, but they happen to be, really a core New York State advocacy group, is a Long-Term Care Community Coalition. They're based in New York City. They host 2 ombudsman programs in the southern region of the state. They compile very up-to-date staffing information, and you can. They have it nationally on an Excel spreadsheet. You can search by name or zip code, and that will give you some really good staffing numbers. If I don't have it in a slide, I will. Yes, I do have it. So the Long-Term Care Community Coalition, you go to nursinghome411.org. It has a searchable data center containing staffing levels and ratios. So what you should be looking for is 3.5 hours of staffing care per day per resident. Anything over 4 is fabulous. We really rarely see 4. Rarely see 3.5. I do see occasionally ones at about 3.2. New York State did recently pass a law establishing minimum levels of staffing. It's a little convoluted. It's not super clear. Have a breakdown of RN, LPN, and CNA hours that's a little bit different from 3.5. The federal government is also in process of passing a minimum staffing law, but 3.5 is really what you're aiming to see. Consumer Voice is another advocacy organization, the National Consumer Voice for Quality Long-Term Care. That's always a great source of information. And that's my contact number. Please feel free to email me or call me if you have any questions at all. If you have a loved one who has any issues or a friend who has any issues in long-term care, and please spread the word. We are always looking for volunteers. We are really desperate for volunteers in Warren and Washington counties. If you know of anybody who might be interested, please share my contact and send them my way by all means. Thank you for the opportunity to present this morning, and I'm happy to take any questions anyone has.
Thank you.
Thank you.
No questions in the chat.
No questions? Okay, good.
Okay.
Thank you.
Oh,
Yeah, lots of thank yous, yeah.
great.
Great. Well, thank you, Mary. That was lovely. That was really great. Thank you very much. We hope that all the information today was super helpful for people. Again, you'll get, there's a recording, and actually we can stop that recording now. That once, I'll have to upload it on YouTube, and then there'll be a copy of that in the meeting minutes, along with the information